Thank you everybody for joining us today. We'll go ahead and get started. Today's presentation is brought to you by Dr. Kia Malhotra, and it is talking about dementia, patient and caregiver communication, and shared decision-making. She is internist geriatrician at Grace Clinic, an adjunct assistant professor with the Department of Internal Medicine at Texas Tech University Health Sciences Center. Before we dive in, we want to take a moment to thank everybody who has made this program possible. This program is supported by DSHS and is operated through the F. Murray Hall Institute for Rural and Community Health at Texas Tech University Health Sciences Center in partnership with the Garrison Institute on Aging. Before we begin, we'd like to take a quick roll call. So if everybody could drop in the chat their name and what organization they're representing, that would be great. And then following today's session, please make sure to complete today's post-session survey. That just kind of helps us improve the future of the program. And then again, I did attach the handout for the CMEs that are available for today's presentation. So please make sure that you download that and follow all the directions to receive the credit. Just as a reminder, please make sure that you mute your microphone. There will be an opportunity for questions at the end of the presentation. With that, Dr. Malhotra, I'll go ahead and hand it over to you.
Hi, everyone. I'm going to talk to you a little about communication in dementia patients with their caregivers, with the patients, and with staff involved in taking care of dementia patients. Can you all hear me okay? Okay. All right. So this is just a disclosure for my business, Reside Ally, which is an online home sharing platform for seniors. And I'm also on the advisory board for Junior League of Lubbock for the elder focus programs. So today we're going to talk under these headings. So first we'll talk about the Spikes-D framework, which is a framework that has been designed on how you can reveal the diagnosis of dementia to patients. We are also going to talk about some evidence-based tools that help in supporting patient and caregiver communication. We will talk about how you can have shared decision making with the patient and the caregiver together to tackle daily life challenges such as driving, medications. We'll communicate the care plan, how to communicate the care plan effectively to caregivers and facility staff taking care of dementia patients, and initiate advanced care planning, recognize caregiver burnout. So why does communication matter? So firstly, the number of dementia patients now living globally is more than 60 million. So that's a large number. And so we need to be able to talk to them in a way that we can relate to them. 50% of these patients never receive a formal diagnosis. So that's a huge problem. 11 million or more unpaid caregivers live in US alone, and more than 1.3 trillion annual global cost of care goes to dementia. So especially in dementia patients, communication failure is huge. One is not being able to reveal the diagnosis. So diagnosis gets delayed or absent, and hence patients lose the opportunity to start planning and what to do for their care in future. Caregiver burnout is a huge problem. 40 to 75% people report significant distress in taking care of dementia patients. One thing that I often say is the dementia patient is not the one that suffers, it's the caregiver that suffers in these cases. Daily life challenges are exhausting for everyone, including driving, medication errors, financial exploitation, especially when shared decision making is not initiated in time. Care plan is very important to design. Physicians plan also, physicians can make a plan with the caregiver, but it has to reach the right people who are taking care of the dementia patient on a day-to-day basis. So communicating this plan is also very important. Legal issues become very important in dementia patients because they can't make their own decisions. They don't have the capacity. And so early planning with advanced directives is very important. And then end of life decisions on what to do in case the patient, codes or requires just comfort care. Planning that is also important. So, as you can see, dementia is one disease where the patient cannot make their own decisions, doesn't have the insight, doesn't remember things. And so, communication becomes a very important part of taking care of a dementia patient. So, here are some of the diagnostic disclosure gaps that we face in our day to day practice. So, barriers to disclosure firstly is the fear that they'll end up causing a lot of distress because there's a lot of anxiety related to the dementia disease itself. And so, patients, family, and caregivers, they fear that if we tell this diagnosis, that'll cause a lot of problems for the patient, cause a lot of stress or distress. There's also diagnostic uncertainty. A lot of patients that I meet on a daily basis, they don't understand Alzheimer's versus dementia versus vascular dementia. So just the terminology is very hard to understand for a lot of them. So, making that terminology clear really helps plan care afterwards. Caregiver request for non-disclosure is an often seen problem. We'll discuss a case related to that later. And then there's lack of communication skills training because especially where dementia patients are concerned, it's very important for the caregivers to know how to communicate with the patient because that makes a big difference to how they're able to manage on a day-to-day basis. There's a lot of cultural norms around truth telling, therapeutic nihilism, nothing to offer. So this is a often believed concept that there's nothing you can do once a patient has Alzheimer's. So there's no point discussing or there's no point talking about it. So but disclosure definitely matters, firstly for the sake of patient autonomy, because even with a dementia patient they may be at different stages, and in the early stages they definitely do understand a lot. And from the point of ethics, it's very important that we give that autonomy to the patient to be able to decide things where they can. And again, it enables advanced directive planning. So, in the early stages, when they can make that decision or when they can at least put their input into it, have a little bit of judgment, at that point, we should start discussing those things. It reduces uncertainty and family distress for sure, because when you've given full information, when the physician has been communicating properly or the provider has been communicating about the disease, then the family feels much more at ease. So that's why it becomes very important too. And then, of course, there's new treatments nowadays. There's newer therapies and trials happening. And so, talking to them about those newer treatments and options that are available would give them the choice. And then after that, if they choose not to do treatment, it's still their prerogative, but at least the provider has to give that option. And then it supports legal, financial, and safety planning. And it builds a therapeutic alliance where you all act as a team. So the provider, the family member, the patient, any other staff or paid caregivers that are involved, you all become part of a team and are on the same page. So Spikes D is a well-known standardized formula that has been come up with for revealing the diagnosis of dementia. So it's very important. So S stands for setting. So it's important that we have a quiet room, a private place to talk, and we give enough time, adequate time when we are giving this diagnosis. And that setting should always include the caregiver, because a dementia patient may not remember. Like even if you've given them the diagnosis a little while later, they would forget sometimes. And so it's important to have that caregiver present over there so they're on the same page and can go back and remind the patient if needed. And then P stands for perception. So the first thing when you start revealing is ask them first what they understand. What do you understand? Have you noticed anything wrong with your memory? Sometimes, and a lot of times, the patients may not have insight into their problem, and sometimes they do have a little insight. So it also depends on the type of dementia. But yes, so assessing first what they know. If they're very resistant and they say, no, 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 I don't have any memory problem, then you would tailor your response accordingly. Versus when they say, yes, I am having some problems, I'm really worried about it. So assess their perception. Then I stands for invitation. So ask how much information the patient wishes to receive. Would you like to know everything or not? Knowledge. K stands for knowledge. Give the diagnosis clearly. So avoid euphemisms. Name the condition. It's very important to be able to tell what dementia is, And then vascular versus Alzheimer's, there are two types of dementia. So Alzheimer's is also a type of dementia. And, the treatment accordingly would vary. So we want to tell them the diagnosis really clearly. E stands for emotions. So validate the emotional response. How are they feeling about it? Are they silent? Are they, are they getting really upset? And so you accordingly might need to maybe schedule a second session to give them more time to process. As just give a little information in the first session, so have them come back soon again in a couple of weeks. So validate and allow them to express their emotions and express empathy for the same. And S stands for your strategy, and that's when you come up with the plan. Again, if the plan, it's too early for them to understand the plan in that first go, then make sure you get them to come back, and you might discuss a little bit of the strategy in the first visit and the first time, and then discuss the rest later. But you should and must, and this is a very common complaint by patients and the caregivers, that providers do not give them any resources. So you might reveal the diagnosis and then they're off on their own and they don't know what to do, and then they're really confused. So always provide them with resources where they can follow up, where they can go for, say, support group meetings, or follow up testing, and what are like alzheimers.org, their nurse line. So give them all that information so they can know where to reach out if they have questions later. So the disclosure conversation, so make the diagnosis, like I said, like for example, based on our evaluation, you have Alzheimer's disease. So normalize the emotions. Yes, this is a lot to take in. Ask, what questions do you have right now? Make sure you open up to questions and give them enough time so you can answer their questions. And it varies a lot. I've seen all kinds of questions. Sometimes they have no questions, and sometimes they'll have all kinds of different questions. And sometimes they want to talk about treatments. So you want to make sure you give them enough time. Offer hope. Yes, there is no cure for Alzheimer's dementia. We know that, but we do have treatments that can slow it down, that can delay the progression, and there's a lot of supportive things you can do to help these patients. So, talk about those. At least talk about what you have right now, and then talk about the research, that there's more research going on. We might come up with new therapies, and support services, of course. Always schedule a follow-up within 2 to 4 weeks, and provide written materials. I usually, in my office, I'll keep, like, alzheimers.org has a lot of written materials on their website, so I have those printed and made packets of those. And so for different stages, like for example, somebody with a new dementia diagnosis, I have a different packet for them, versus somebody who doesn't have dementia, is trying to prevent dementia, versus somebody who's in a late stage and the caregivers need more help. So always give those written materials out wherever you can. Don't ever use euphemisms like just a bit of memory trouble. Don't try to vague it. Okay, it's very important that you specify the diagnosis. Don't do it on the phone, and that's something that we all providers follow for grave diagnosis such as cancers. So I would use that same philosophy here, that make sure they come into the clinic and talk to them face to face. And then don't overwhelm them with too much information at once if they're not ready. So you have to assess how much they're ready to take. And then always have that plan at the end, and don't ever promise outcomes you cannot guarantee. And you want to be also very clear that you don't make them believe that those medicines can be a cure. So I usually draw out a diagram and tell them, okay, here is the graph for dementia. It's going to go like this, but if you take the medicine, it's going to go slower, but it'll still go downhill. So especially with Alzheimer's, we know it's a progressive dementia. So you want to make sure you explain to them that you're not giving any treatment to cure it, but to slow down the progression. So we're going to talk about SDM, which is the topic of this discussion mainly today. So SDM stands for shared decision making. So shared decision making is the process where three people are involved, mainly the patient, the clinician, who's at the center of that decision making, and then the care partner. Care partner could be one or more. So it could be a family member who's directly related to the patient, like a spouse or a child, or it could be a family member and a paid caregiver. So somebody they are hiring through an agency who's coming and taking care of them some hours or several hours throughout the day. Or if the patient is residing in an assisted living facility or a memory care unit, it could be the staff over there. So that too is part of the care team. And so the principle here in SDM is that it's not one person that you're going to be talking to. It's going to be the patient and the caregivers involved. So decision making has to be a shared process, and this is an evidence-based concept that first came out in 1982 by the President's Commission for Ethical Problems in Medicine. So it's an ethically valid consent, where a process of shared decision making is based upon mutual respect and participation, and it's not a ritual to be equated with reciting the contents of a poem. So that's what they initially said. So evidence based, it is evidence based because we found through a lot of trials and stuff that this improves health quality of life. It reduces decisional conflict, because especially when people are on different pages, it's important to bring them all onto the same page to take care of the patient. And of course, it preserves personhood, which in turn, very importantly, reduces the behavioral problems, which is one of the main goals of shared decision making. Because if the patient is on one thought process, no, I want to keep driving, say, for example, whereas the caregiver says, no, no, he's absolutely unsafe to drive, and you don't talk about it, then that leads to a lot of anxiety, which in turn manifests as agitation or resistance to care by the patient, which makes it just harder for the caregiver to manage at home. And of course, depression. So we found that shared decision making will decrease these behavior symptoms, and patients can reliably express values even as cognition declines. So we know that early stage patients prefer the greatest say in their own decisions, and we should definitely include them based on their level of dementia. For the caregiver, like I said, if the behavioral symptoms are less, then definitely it's going to be easier for them. Life will be easier, and they also have less regret and less guilt. They don't feel that, okay, I have to make all the decisions. So when we include the patient in that decision making, the caregiver feels better about it. So a lot of shared decision making tools have been developed. There's like more than 20 tools that have been developed, but these are some of the popular ones. So talking mats, we'll talk about it a little more. It's a visual tool. And again, it's for the three people we talked about in that triad. It's widely validated. 40 plus countries have been using it. And then there's also one called Decide Guide. It's a web-based one that you could actually pull up in your office on the computer. And users feel more involved in this. It has a chat function, valued collaborative deliberation model. So it's also a conceptual framework. Then there's another one called Serious Illness Conversation Guide. So it's a structured dialogue. So this is what talking maths looks like. So, you give them a topic, say like, okay, what time do you want to eat breakfast? For example, would you like to eat it at 8 o'clock sharp, or when you wake up at 12 o'clock in noon? So, and they say, okay, you want to eat breakfast at 8, and they say whether they're happy or unsure or unhappy. So they just point to one of them. And so say if they say unhappy, then that's not what they'd like. Then you give them another option. So it's like a card system, and it's a visual guide, so it makes it much easier for especially a dementia patient who is struggling with words or struggling with reading and understanding comprehension. So it's a really great tool, and you could get one of these and keep them in your office if you'd like. And decision making will vary based on the stage of dementia. So it starts early. Dementia patients will have different kind of questions versus an advanced dementia patient. And so in the early stages, we have to talk about driving. So driving becomes very important, because here you have an adult who has been independent, doing everything for themselves, and suddenly now when they are in those early stages, such as mild cognitive impairment or early mild dementia, they somehow have to be told now no more driving. And so that becomes a very important topic, an issue that has to be communicated properly, and we'll talk a little more about it later. Finances is another issue, because they might be blowing up their bank account by being involved in scams, and we see that sometimes. And so that control of finances now has to be moved on to that caregiver, which can be hard. Advanced directives is something you should always talk about early in dementia, as soon as possible. In fact, we don't even want to wait for dementia. As soon as you have a 65 and older patient, advanced directives should be done as part of those visits. And then treatment goals, diagnostic testing. So what path do they want to take? There'll be patients who will say, no, I don't want to do anything about it. I don't want to manage it. I'd be the way I am. Versus there's patients who say, no, I want to do everything. And so you discuss what they would like to do, the caregiver and the patient, early on. as the disease progresses. So you want to make that care plan early and then document it for later. And then mild dementia, you start talking about home safety, medication management. Are they forgetting their medicines? Are they able to take it? Who's going to come and fill the pill box for them once a week? What are they going to do for activities? Should we enroll them in a senior center where they can go once a week, or have grandchildren come, or should we continue to do church? So things like that. And the caregiver's role. So that also starts becoming important to discuss, because here you might have a spouse who's having to do everything and they're getting overburdened. And so that's when you start telling them, hey, start involving more people. You need to tell your son or daughter, I'm not able to cope up. I need at least 1 week off, 1 day a week off, or 1 day a month off. And, I need to get you involved. So these are talks that you should start doing at that stage. And then talk about clinical trials and treatments, of course. In moderate stage of dementia, you have to talk about the behavioral symptoms and management of those. So if they're getting agitated, then you have to speak about how we can manage that. What are the changes you can make around the house to decrease that agitation? If they're not remembering things, where the spoons go in drawer, maybe label that drawer. So simple things like that, you want to come up with those. Talk about respite care, so that the caregiver gets a break, where the patient can be moved to a facility or a place for a little bit. And then talk about long-term placement. So if they're not safe at home anymore, if they're not able to, a caregiver cannot stay with them, they need 24/7 supervision, this is the time you want to start talking about, hey, do you want to move to an assisted living, or do you want to move to a child's home? So where would you like to stay long term? And talk about, in advanced stages, talk about what are your goals of care. Is hospice the right step, and what would we achieve out of hospice? It's very important to clarify, because hospice is misunderstood by a lot of people, especially as soon as they hear dementia, they're like, okay, we should put them on hospice. Some people think like that. And so you want to make sure you explain that hospice is fast stages. There's the fast staging for dementia. So stage 6 and 7, when the patient stops walking or eating, and they forget to swallow, so that's why they stop eating. So feeding decisions become important at this point. So here's when hospice would admit them, ideally, because we don't want to misuse hospice. Hospice should be an end of life decision during their last stages, when they're in the fast 6 or 7 stage, because after that point is when you stop treating or preventing any other medical conditions also. So you want to discuss all of this clearly with them, and see what their end of life wishes are, what they'd like to do, where they would like to be. So communicating with the patient. So here, you have to use very simple language. So you don't want to use long sentences. It's very hard for a dementia patient to understand, difficult long sentences. So keep it really simple. Like your memory test showed some changes. Okay. So then use visual aids. So draw diagrams, graphs, like I said, I would draw to show them how quickly it's going to progress. Check their understanding. Are they getting what you're telling them? And make sure you maintain dignity always. So this is very important. We always providers tend to start looking at the caregiver when the patient is quiet, he's just looking here and there, looking at the caregiver, not responding to you. You tend to start looking at the caregiver and not even talk to the patient. But that's not correct. You should always be looking at the patient. The way I do it is, the patient is in front of me, caregiver is behind. So I'll always look at the patient for most of the time, like 70% of the time, and then 30% in between I'll keep glancing at the caregiver, so they know that we're addressing both. So and then allow processing time. Make sure you give them time to understand. You have to be slow. So you say one sentence, pause, give them time to understand, because with their cognition going down, it takes longer to process every piece of information. And then adapt to this stage, of course. So if they are early stage, you want to involve them more versus late stage. So the caregiver communication and support. So caregiver impact, the evidence. So 11 million plus unpaid caregivers, we talked about that. 40 to 75% report clinically significant distress. That is huge. So distress just because you're taking care of a dementia patient. And a lot of that is caused because of agitation and psychosis and sleep disruption. They're not able to sleep. Sometimes dementia patients have disrupted sleep cycles. And so they'll keep waking up at night. How do you manage those? What medicines do you give to allow the caregiver also to get a rest at night? And so education becomes important. And so you have to end up treating the caregiver as well as the patient. So there's a caregiver strain instrument that you can print off the internet. I have that in my office too. And so I'll hand that over to the caregiver and say, hey, do this. It has questions about, how are you doing with social or financial or your exercise. And you have to explain to the caregiver, you can only take care of the patient if you take care of yourself. So you have to first focus on yourself and, continue to take good care of yourself, because the dementia patient won't even recognize, they won't even remember. So at the end of the day, the caregiver has to continue taking care of themselves. So here the goals are that you want to talk about disease strategy, give them the resources like the Alzheimer's org helpline number, the area agency of aging, respite services, discuss self-care, and then plan for transitions. So shared decision making in daily life, driving is one big one, like I had said earlier. So I'm sure you all know occupational therapists can do a formal driving assessment for dementia patients, and they'll take them out in their own car outside on the street and see how they do, and they write out a report to say that is the patient safe to drive or not. So this is very helpful, and I've used it a lot, to be honest, because when you are stuck between the family member saying, hey, this person should, my dad shouldn't be driving at all, he's unsafe, and then the dad says, no, 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 I'm absolutely fine, and you as a clinician, you want to continue that rapport and the trust with the patient, and you obviously haven't seen them driving, so you really can't make that decision sitting in the office. So then I say, you know what, let's get you in with this occupational therapist, they can take you on the road and see, and they're not going to take your license away, they're just going to give a report, and you'll be able to show the report to your family member and say that, hey, I'm a good driver, versus the other way around. So it gives them a choice there, and also a clear cut path on how to make that decision. So similarly for medications, who fills the pill box once a week, fall prevention, whether they should be using a walker or not, finances, who is the financial power of attorney, social activities, home safety, should you have an alarm on the door. So little things like that, it's important to keep discussing those in that decision making process. And then talking about the care plan, with the paid caregivers. So that becomes very important, because you might tell them a lot of things in the office, but then when it doesn't reach, if they have a paid caregiver, it doesn't reach them, then there's no point. So provide a written care summary, talk about, what triggers they need to watch out for the caregivers, and how to manage those triggers, the sundowning pattern, the sleep schedule. Give them a daily routine card to fill out. So, okay, this is their wake time, this is their sleep time, this is when they eat their meals. Also, medication sheet, always print out the full list of medications that the caregiver can use to fill out the pill boxes. And then a communication notebook. They should have the ability to be able to call your office and discuss things if there is some problems. And so if you have a nurse 24 by 7 CCM chronic care management nurse line, you could use that, or your own staff in the office. And they should know when to call 911. Now 911 is a tricky thing in dementia patients, because a dementia patient might be aggressive, might hit the caregiver, but if they call 911, they actually don't have the capacity to make that judgment, so they're going to end up sending them to the ER. So you have to be, and it just makes the patient more and more confused. So if a patient is going to the ER, they are in a new setting, they're sitting with all that noise around them, so we want to avoid those situations. So as much as possible, have some PRN medications on file, have some resources for them to know what to do in those agitation situations, that they don't have to call 911, they don't have to rush to the ER. Okay, and so then, of course, facilities. So if they are in a nursing facility or in a skilled, assisted living memory care unit, then just communicate that plan that the doctor has given to, or the provider has given to the staff. So you want to be able to make sure that the staff is on the same page always. And remember that the staff in these facilities, they are not allowed to do anything until it's in the care plan. So that's very important to remember. So everything has to be given directly also through the physician's office to the staff. So for example, if you want the patient to be drinking water, say every hour, put that in the care plan, simple things like that. Or if they are having pedal edema, you want them to raise their legs, put that in the care plan. So, and don't rely on PRN medications and facilities, because the patient is never going to be able to say that, hey, I'm in pain, give me medicine. They don't have that cognitive ability if they're at that stage that they're in a facility. So at that point, you as a physician should understand that, okay, it's the patient is having pain most of the days, let me just put a Tylenol on file every day, let's not use it as a PRN. So these are little things that you need to communicate clearly. And then talking to your loved one with dementia, so this is for family members, and there's a lot of such resources. Actually, I pulled this out from the alzheimers.org website only. There's a lot of such resources over there, and you can print these out for them, or the patients should be given the website link at least to go and look. So the caregiver, it just makes a huge difference the way they talk to the patient, the dementia patient, and they don't realize. So for example, especially a spouse, like a wife who's been used to talking to her husband in a certain way, and suddenly she has to now change her whole way of talking. This is going to be hard, and it has to be a conscious process where they have to change their way of talking and start talking short ones, sentence explanations, slowly start, not expecting them to answer always correctly, and if there's confrontation, leave the room. So, and they have to remember the disease is different from the person. So in a lot of times I've seen, especially female spouses, they get very overwhelmed with emotion that, my husband's not responding the way he used to. And so you want to explain to them that, the patient is different from the disease. What you're dealing with is the disease now. So it's hard, it's very hard for them, but this, all of this needs to be communicated to them. Caregiver support group meetings help a lot, because when they're sitting in that setting with other family members, they are able to talk and discuss and see, like, what would be the best way to handle this situation or that situation. So putting it into practice, like I'll give you one example here. There's a few examples. The patient says, I didn't write this check for $500. Someone at the bank is forging my signature. So instead of saying, don't be silly, the bank wouldn't be forging your signature, that's not the right response the spouse or the family member should give. They should instead talk to the patient about their feelings, because obviously the information that the patient is giving is not correct, but the feelings are. So you would say something like, that's a scary thought, I'll make sure they don't do that, would you help me fold the towel? So redirect them, right? So there's no point countering them, they're not going to remember even if you tell them something. So just calm them down at that point, address their feelings, and then redirect them to something else. So these are better approaches to use in communication. Mm. Okay, so cultural humility is important. So, language, health literacy, you have to take that into account, because if a patient is Spanish speaking, and I've even seen dementia patients, like, say, if their primary mother tongue was Spanish, for example, and they had learned to talk English, by the time they have late stage dementia, they would have forgotten their English. They go back to their mother tongue. So, you have to remember those things and don't expect them to adapt to you. You have to adapt to them. And advanced care planning, we had talked about that. Start early when they can make those decisions. Make sure there's a durable medical power of attorney listed early on, so they are not in a situation where they get abused, or somebody's taking advantage of them. And that's very, very important, especially in vulnerable elderly patients. And so, caregiver well being, we talked a little about that. So, recognize caregiver burnout at every stage, make sure they're getting their sleep. And if that requires giving a sleep medication to the dementia patient, that's important, because if they can't sleep, they're going to be more irritable next day with the dementia patient. And when they're irritable, they're going to cause more agitation. So, it becomes like a cycle. So, if it requires just giving a sleep medication to help them be able to manage their care at home comfortably, and if it can avoid putting them in a situation where they say, I just can't take care of them anymore, I have to find them a nursing home. If you can keep them home longer, that is always best for a dementia patient. So if that requires medications for agitation or for sleep, use those. And then hospice. So we have talked a little about that. So when to raise the topic. So we had said fast stage 6 or less. So when they're not able to communicate, not able to even sit up or hold their head up. So these are changes that occur in late stage dementia. So that's when you would talk about hospice and start bringing that up and say, hey, this is not going to matter anymore. They sooner or later are not going to be able and lose weight, and most dementia pneumonia because they forget how to swallow. So because of those weak muscles, food trickles down and they get aspiration pneumonitis, trickles down the lungs. And so those are the common causes. And then there's malnutrition. When they forget how to swallow, they're not able to keep their food up. Is feeding tube an option? Probably not. So these are the things you want to talk about, because this is end of life. What is our goal? Where do we want to go? Okay, so let's talk about the case here, and I'll need you to probably unmute and participate. So I had a 74-year-old patient. We'll call her Mrs. R. So PCP referred her for PCP referral was given for 18-month progressive memory loss. A MOCA testing was done in office, showed 18 out of 30. So that puts her in mild dementia category. MRI of the brain was done. It showed a medial temporal atrophy, so probably frontotemporal type of dementia. But the CSF analysis showed Alzheimer's pathology, so we know it's Alzheimer's disease. And she was accompanied by her daughter. And so she said, please don't tell my mother she has Alzheimer's, it'll destroy her. So Mrs. R said, I know something is wrong. I just want to know what it is so I can plan accordingly. So how do you handle the daughter's request to withhold the diagnosis? Anybody?
I think that you have to explain to the daughter that the patient is entitled to know, maybe explain to the patient where the patient can understand what's going on. I think she needs to know.
Yes, wonderful. So, yes, we have to make sure we advocate for the patient. So, a physician should always be a patient's advocate, right? And so, you want to tell them, no, it's not ethically right that the patient doesn't know. And so, we should tell. Absolutely correct. So, how would you structure the disclosure conversation using Spikes D? Anybody? So basically, we talked about Spikes D earlier. So you want to make sure the setting is right. You give them a chance to process it, ask questions, and you see what their emotions are about it. So it seems like here in this particular example, the daughter is getting very anxious, right? So the daughter is getting worked up. So you want to explain to the daughter that she's not probably going to remember, but we'll tell her only as much as she understands, and we can always get you to come back and then we can talk more. So you have to calm the daughter down also here. And then what shared decisions need to be initiated at this visit? What do you think?
Treatment plan, how to, you know, what they want to do from the diagnosis, how they want, do they want medications? Do they want, just the treatment plan?
Yes, that would be very important. So, because this is that first visit, we have a diagnosis now. We've done the MRI, we've done the CSF testing, probably a neuropsychological testing. So, you would want to do that most likely to get a more, confirmed diagnosis. So, you would talk about that. Do you want to do that? And then, yes, address any depression, because depression is very common in Alzheimer's. So, you want to treat that too. And then, yes, talk about Alzheimer's treatment. So, offer them all the options that are available. You always want to let them have the say, and give them all the options without the knowing what options are there for treatment. You cannot say this way or that way. You don't want to be the one making decisions for the patient. So the patient and the caregiver have to be involved in making that decision. And so then give what resources and follow-up would you arrange? Anybody?
Maybe some places that they can get, like Garrison, support groups, Garrison House, some places they can get more support.
Yeah. Mhm. Yeah. So it sounds like this daughter, obviously, is worried. And so the support group meetings, either there are meetings where the family member can go by themselves, or you can take the patient with you. So I think they would really benefit from going to support group meetings where where the patient and the family member, the daughter, both Mrs. R and the daughter, both can go together. So they can understand and talk to other people in that stage of dementia and see how to manage it going forth. So yeah, those resources, you can give them a list of caregiver support group meetings in that area wherever you are. Okay, so yeah, so we talked about these. Let's see if there's anything we missed. And then the follow-up meeting. So that's going to be really important
Yeah.
in 2 to 4 weeks. Yeah. All right. And so, key takeaways from this discussion, disclosure is not optional. It is ethical and clinical standard. We have to disclose the diagnosis. Patients have a right to know their diagnosis. Use a structured framework like the Spikes Ds to guide you and for you to understand how to give that diagnosis. Shared decision making in dementia is triadic: patient, caregiver, clinician. All three have to be involved. Keep the patient at the center even as the capacity declines. So depending on the capacity of the patient, you can alter the amount of information, but you always keep the patient still at the center and address them when you're talking to them. And begin advanced directive care planning early. Capacity is time limited because, yes, as the dementia progresses, they are not going to be able to make that decision, but in early dementias they can, so do it while they can. And then keep revisiting those goals also. Communication is a clinical skill. It can be taught, practiced, and improved. So invest in training at all levels. Treat the caregiver as well as the patient. Access the caregiver burden and well-being at every visit. So that's very important, especially as the dementia progresses. Caregiver burden will increase, and you want to keep addressing that as we go along. So the way we communicate the diagnosis shapes everything that follows. Thank you. Okay. Any
I have
questions?
a question, Dr. Malhotra.
Yes, go ahead.
We do chronic care management, and we speak to the patients via phone,
Mm-hmm.
but we get to know these patients, and sometimes in talking to the patient or even the caregiver, uh, we find that, they've been having memory issues or,
Mm-hmm.
some cognitive changes. How, as chronic care management, what can we do? How do we go about helping these patients? Do we need to start off by letting the doctor know, or how do we
Yeah.
do that?
So, right. So, in early stages of dementia, when it's just about to start, or in mild cognitive impairment, anybody could pick it up. Sometimes the spouse doesn't. A lot of times, even the spouse or the children, they don't pick it up because they see them on a day-to-day basis and they just assume it's normal aging.
Yeah.
So, so it's like any person, like if I've had my medical assistant point it out, so because a medical assistant who's been with me and been seeing the patient also over the years, she has come up to me and said something is odd today, she didn't remember this, right? And so you as a chronic care management team should also be on the alert for sure. And as soon as you notice any signs, that's when you contact the doctor for sure, and or the provider, whoever is the PCP for the patient, and get them to come in to do a dementia testing or refer for dementia testing to either a geriatrician or a neurologist or whoever in the area does it. So that early dementia screening testing visit is very important. So in my clinic, I always do a MOCA. Most doctors might do a MMSC. So the difference is the MMSC doesn't always pick up early dementia, whereas the MOCA sometimes will have a higher threshold for picking up. But either testing is important, and so you must try to coordinate and set that screening testing for the patient. That's
Okay.
very important.
All right. Thank you.
What else? Any other questions?
Doctor,
I just want to tell you, Dr. Malhotra, I appreciate this particular information because I had to deal with my mother's dementia, and I had caregiver burnout, and
Yeah.
it happens. And boy, so it's good
Yeah.
to know that you're saying that people have to not only take care of the patient, but they're caregivers. So excellent.
Yes, yes, I can empathize with you. I know it's a big struggle for a caregiver who's taking care of their dementia family member or loved one. And yes, and having all that information ahead of time really helps. So,
Yes, ma'am. Yes, ma'am. Thank you so much.
any other questions?
Dr. Malhotra, I do have a question. So I know a lot of this, so you and including a lot of the previous speakers have mentioned how important the caregivers are. So in rural areas, maybe patients may not have their families there living close to them. So in places where like individuals don't have family members or don't have family members close, like what is what are the following steps?
Right. So, it depends on their financial situation a lot of times. So, if they can afford healthcare agency staff to come out to their place and take care of them at least a few hours a day, that would be great. So, there are healthcare agencies that go out in the rural West Texas area, and they do have staff. So, if you can book them for like 2 hours every day, and they might just come and set their medications, make sure they've taken their medicines. You could also use technology, which is really growing now, and so there's so many options. Having them wear a watch which has GPS in them, or putting up cameras in their house where you can watch, or alarms on the door if they leave the house to wander. At least that alarm rings on a caregiver's phone. So there's so many apps nowadays where you can track them while they are at home. And new technologies are being developed for that still. And so things like that can help, along with, like I said, healthcare agencies. If you can enroll neighbors, if they are in good terms with their neighbors, and you get them to come check on them at least once a day, maybe just make sure they are still alive and everything's okay. Just even that helps a lot, goes a long way. So things like that can be done.
Go ahead, Melinda.
Thank you. Thank you for an excellent presentation. I know you mentioned the concern with 911 calls and how that can escalate and end up somewhere you don't want to be. I wondered if you've had any experience with the relatively new number. I think it's 988, but please correct me if that's not it. And it's more of a mental health service. And those people are really good at de-escalating sometimes. And I just wondered if anyone on the call or you have had experience with them, because I have not tried it yet, but some of my patients have talked about it.
Isn't 988 the mental health line number, right? If I'm not
Correct.
wrong.
I believe so. I believe so.
Yeah, they might be really good at it, but I think they're more for depression and suicide. I don't know how familiar or comfortable they would be with dementia patients. So I can't say that. I don't know if anybody else has experience with that.
Yeah, we've used them for a bipolar situation that escalated, and they were excellent, much better than the police department, actually, 911, just because of the training on any kind of mental health difference. So I wonder if that might be an access, a good resource in the future, but I haven't had personal experience yet.
Yeah, so definitely they might be better than 911 for sure. But I would also encourage you to give them the Alzheimer's nurse line number, because that's a 24-hour line, and they have that valuable resource. And I've had my patients use it and they love it, because if they're in the middle of the night, they don't know what to do, patients trying to get out of the house, drive off somewhere, something like that. They can just call that nurse line and say, hey, what should I do? What should I say to him to make him stay and not walk out of the house? So simple tips like that, they're excellent at guiding them. So you could use that too.
That's great. Thank you so much.
What else? Any other questions?
I just dropped the link to that helpline in the chat. So if anybody wants that.
Thank you for doing that.
All right. I guess we don't have any other questions. Thank you so much for today's presentation. That was very informative and I really enjoyed it. So once again, everybody, make sure you download the CME handout and follow all the steps to receive credit for today's session. I'm going to post the ECHO post-session survey in the chat, and I'll stay on for a few minutes if anybody wants to complete that while they're on here. But thank you so much, Dr. Malhotra. We appreciate you.
Thank you for having me.
Yeah. Bye, everybody. Have a good day.